Okay, hello guys. Good day, good evening, or good afternoon. It's me, Miss Merle, once again. Today we're diving into some fascinating immunohematology techniques centered around the antiglobulin tests. So, first, let's highlight the two types of tests. We have the direct antiglobulin test, or DAT, and the indirect antiglobulin test, known as iAT. These tests are essential in checking for antibodies that might be stuck to red blood cells, providing crucial insights into conditions such as hemolytic anemia or transfusion reactions. And then moving on to gel card technology, also known as your column agglutination technology, or CAT. This innovative method utilizes gel particles to separate and identify the presence of antibodies. And through centrifugation, red blood cells interact with the gel, making it easier to detect agglutination results. Lastly, the anti-human globulin test is a cornerstone of these techniques, so it helps in identifying antibodies bound to red blood cells by using anti-human globulin serum. And this test is pivotal in both clinical diagnosis and transfusion medicine. Now, as we transition to the objectives of our laboratory activity, let's keep in mind how these tests contribute to our understanding of blood related conditions. For the objective, at the end of this laboratory activity, you as the students must be able to, based on the core knowledge and principle, should be able to explain the principle of gel technique. So describe how the buffer gel solution and centrifugation work together to filter and trap agglutinated red blood cells while allowing unagglutinated cells to form a pellet. You should also define the reagent composition. So by identifying the specific components of the DG gel Coombs microtube, so what's inside it, including the mixture of polyclonal anti-human IgG and monoclonal anti-C3 C3D antibodies, and to contrast DAT from that of IAT, meaning to differentiate between the direct antiglobulin test, which is detecting in vivo sensitization, and the indirect antiglobulin test, which is detecting in vitro sensitization, and their respective clinical applications. Second major objective, is for the technical procedure. So specifically, you should be able to execute sample preparation. So by demonstrating the correct preparation of a 1% red blood cell suspension using the appropriate diluent and specific volumes. So it's 10 microliter packed red cells in 1 ml diluent. So that's the DG sol. And then differentiate procedure workflow. So correctly perform the distinct steps for DAT and AAT testing, both using the conventional or manual method and that of the gel card technology, or CAT. And then maintain storage and stability. So by outlining the mandatory storage conditions, 2 to 25 degrees Celsius upright, and identify the observable indications, so like bubbles, cracked gel, or dried supernatant, which all of them render the card unusable. So whenever you can see bubbles in the card, or the gel inside the card, the gels are cracked, or the supernatant gets dried, then it's the card will be considered unusable. And then also another major objective is for the results and interpretation. So specifically, you should standardize agglutination grading. So by accurately grading reaction, so intensities from negative to 4 plus, based on the position and size of red blood cell clumps within the gel column. And number eight is to identify double population or a mixed field reaction. So should be able to recognize and interpret, guys, double population result and explain its potential causes such as recent transfusions or bone marrow transplants. And another major objective is based on quality and troubleshooting. So the ninth specific objective will be to assess limitations and interference. So analyze how factors like Wharton's jelly, high dose IV immunoglobulin, or fibrin residues in plasma can lead to false positive or non-specific results. 10. Implement QC, or quality control, by formulating a plan for including positive and negative controls in daily workflows according to laboratory policy. And lastly, we have to manage post analytical stability. So determined by determining the appropriate conditions for delayed grading of results up to 24 hours and the necessary steps to prevent evaporation. So for the history, I don't know how to read this his name. It's Dr. Ives Lapierre, a visionary in the field of immunohematology, and he pioneered the development of gel tech in 1985. So his work took place in Lyon, France, and fundamentally reshaped how we approach the separation and analysis of red blood cells. And initially, Dr. Lapierre experimented with a variety of materials, including gelatin, acrylamide gel, and glass beads. And this experimentation was crucial for finding the most effective medium to trap red blood cell agglutinates. And ultimately, gel particles were chosen for their superior ability to facilitate standardized sedimentation and centrifugation. And this led to a patented process that revolutionized RBC separation. So, as we move forward, guys, we'll explore how these advances in gel technology have continued to evolve and their significant impacts on procedural efficiency. So, the procedural efficiency brought about by gel technology and antiglobulin testing is quite outstanding. So, this innovation led to two major shifts. So, first, it eliminated the very cumbersome process of multiple saline washes to remove unbound immunoglobulin. And this not only streamlined the testing process but also reduced the potential for user error. And secondly, the technology removed the need for antiglobulin control cells, commonly known as check cells, to verify the presence of reagents in negative tests. And this was a significant advancement in simplifying the workflow and improving overall efficiency. So now let's highlight the advantages of gel technology over traditional methods. The gel method provides a more stable and permanent endpoint, and it ensures that our results are not only reliable but also easier to interpret over time. And moreover, gel technology enhances reproducibility. So it offers consistent results across different tests, which is crucial for maintaining quality and reliability in laboratory settings. Lastly, the reduced variability is a key benefit. So, by minimizing errors linked to the manual resuspension of red blood cell buttons and the subjective interpretation of heme agglutination, it ensures that the process is both accurate and efficient. So, these advancements have really revolutionized laboratory practices, making gel technology an integral part of modern blood testing or blood banking. So, here in this slide, we're going to explore the very important essential moments in history and the commercialization of gel technology. So, first, let's look at the European development in 1988. So, this is when Dr. Ives, I think it's Ives Olapia, joined forces with Diamed AG to bring the gel test to the European market. And this collaboration was a significant step in making gel technology broadly available and setting the stage for global use. So next, we'll move across the Atlantic to the US. So here, licensing in the US. Licensing milestone in September 1994. So the FDA approved microtyping systems, MTS, to manufacture and distribute two types of gel cards. So an antiglobulin anti-IgG gel card and a buffered gel card. And this was a crucial development as it allowed these advanced testing methods to be adopted in the United States, enhancing the accuracy and reliability of blood testing. So these developments marked the beginning of a transformative era in blood testing, enabling the widespread adoption of gel technology and setting the stage for further enhancements. And for next, let's start with the North American distribution. In January 1995, Ortho Diagnostic Systems Incorporated, or ADSI, and Microtyping Systems formed a significant partnership. So they signed an exclusive agreement granting ADSI to the sole rights to distribute the gel test across North America. And this was really an important moment for the expansion and accessibility of gel technology in this region. Fast forward to March 2002, we see another major development, and Orthoclinical Diagnostics fully acquired MTS, marking a complete integration of MTS into their operations. And finally, let's talk about product branding. The gel based testing system we've chosen discussing is officially branded as, we have ID Micro Typing System. So this is from what reference book? Denise Harmony. That's ID microtyping system. But the one that we will be using in our laboratory exercise will be the one from Grifols, Spain. So okay, that's it. Next, so what's the core principle behind gel card technology? So if you'll be asked with a question, you need to answer me controlled RBC filtration and centrifugation, because at the heart of this technology is the process of controlled, again, RBC filtration and centrifugation. So imagine a specially designed microtube where this fascinating process takes place. The gel test operates by controlling the centrifugation of red blood cells, or RBCs, through a dextran acryl amide gel. This gel isn't just any substance; it contains pre-dispensed reagents that are crucial for the test effectiveness. So antibodies, or a complement fragment. So the key principle here is size exclusion. So again, the principle, controlled RBC filtration and centrifugation, and the very core is size exclusion. So as RBCs move through the gel, their size determines their journey. So larger clusters might get trapped while smaller ones slip through. So this innovative approach allows for precise and reliable testing outcomes. So this time, let's dig deeper into the principle of gel card technology. So let's focus specifically on the reaction process. So let's break it down step by step. First, we have the reaction phase, where a patient's red blood cells are no the patient's red blood cells are mixed with specific antibodies or agents right at the top of the microtube. That's the microcolumn, or no, that's the reaction chamber, sorry. So this initial step is crucial as it determines the interaction between the red blood cells and the antibodies. Next, we move on to centrifugation. So this is where the magic happens. The card is placed into a specialized centrifuge, which helps to apply the necessary force for the separation process. And finally, we have filtration. So the gel acts as a molecular sieve during this stage, during filtration. So if the red cells react with the antibodies, they form large clusters called agglutinates. So these agglutinates are too big to pass through the gel matrix and remain trapped at the bottom of the column. So conversely, if there is no reaction, the individual RBCs are small enough to pass through the gel pores, forming a pellet at the bottom of the tube. So this differentiation is key to understanding the results of the test. So guys, understanding these steps gives us insight into how gel core technology works and highlights its significance in providing accuracy and efficient diagnostic results. So the gel technology plays a crucial role in blood testing by utilizing the properties of gel particles, which are made up of, again, what? Dextran acrylamide gels, or beads. And these beads form a significant 75% of the gel liquid mixture in each microtube, preloaded by the manufacturer. So the porosity of these gel particles is the key. They act as both a reaction medium and a filtration system during centrifugation, which can effectively sieve RBC agglutinates based on their sizes. So this process ensures that only specific size particles pass through, aiding in accurate test results. So remember, the effectiveness of the gel's sieving mechanism directly impacts the reliability of the test outcomes. This highlights the importance of understanding the gel's composition and function in the clinical settings. So in this slide class, we'll tackle the separation mechanism of the gel card technology, focusing on how the gel acts as a sieve to determine the outcome of the test. So first and foremost, let's consider large agglutinates. So the large ones, no. So when red cells or RBCs agglutinate, meaning they clump together into large clusters, they're too big to pass through the gel spores, and these clusters become trapped at the top of the gel column during centrifugation. Next, we have small or partial agglutinates. Well, depending on how strongly the RBCs react, these smaller clumps may get hot or various levels within the gel medium. So this shows us the gradation of the reaction strength. And finally, the unagglutinated RBCs, which are individual and free floating, can move through the gel column without obstruction. They settle at the bottom of the microtube, forming a pellet, which indicates a negative result. Mhm. And this separation mechanism is important because it visually illustrates the test results, allowing for something straightforward interpretation of whether or not agglutination has happened. And as we moved to the next slide, we'll explore the grading of these reactions and their clinical implications in more detail. So this one, it's based from the book of Harmoning. So from the source is Harmoning for this one. So if when discussing the grading of a gel agglutination, it's really essential to clearly convey the meaning behind each grade so that the audience, you as the audience, or what the students or the ones listening can understand the implications of the results. So, guys, let's walk through the key points for each reaction grade, starting with the strongest reaction. What's the strongest reaction? Is a 4 plus reaction. So, you're looking at a solid band. There's a solid band of agglutinated red blood cells that remains at the top of the gel column. At the top of the gel column, indicating a strong reaction. And then moving on to 3 plus reaction. So while most agglutinates still stay near the top, you may notice a few staggered below the main band. And this suggests or implies a slightly less intense reaction, of course, as compared to a 4 plus grading. Now, 2 plus reaction shows agglutinates distributed throughout the upper and lower halves of the gel. Again, the agglutinates are distributed throughout the upper and lower halves of the gel, with a few cells making it to the bottom. While plus one reaction, the agglutinates are mainly found in the lower half, so just mainly on the lower half of the gel, and some RBCs can be seen at the bottom, so this indicates a weaker agglutination. So a weak reaction is characterized only by a few agglutinates remaining in the gel and specifically just above the cell pellets. And lastly, a negative reaction is evident when all red blood cells form a distinct pellet at the bottom with the gel above remaining clear. So you should remember that the gel above should remain clear, and this indicates the absence of agglutination. Again, this will mean there is no agglutination happening. So, again, guys, by understanding these grades, you can better interpret the results and make informed decisions in your clinical practice. So, here, there's a special thing that might happen to your results, and something like what we call a mixed field reaction. So, when examining the gel test agglutination grading, it's important to understand what is a mixed field reaction and what are its clinical implications. So, first, let's talk about the appearance. With a mixed field reaction, you'll notice a layer of agglutinated cells at the top of the gel and a distinct pellet of unagglutinated cells at the bottom. So, this pattern indicates the presence of multiple populations of cells. So, it's not just one, it's like there's a multiplicity of the cellular population coming from the patient. So now, why is this clinically relevant? Because mixed field reactions are commonly observed in patients who have recently undergone a blood transfusion or a bone marrow transplant. Remember, these procedures result into the coexistence of different cell populations, which can affect the test results. Another essential point to consider here is the possibility of false positives. So these can happen if the serum isn't completely clotted, leading to fibrin strands that trap the cells at the top of the gel column, which mimics a positive reaction. So this could be misleading and must be carefully managed to ensure accurate diagnosis. How about the applications of gel tech? Okay, so we have for ABO grouping, essential for determining blood type necessary for transfusions. It can also be used for RH typing to identify RH antigens to prevent severe transfusion reactions. We can also use it for DAT in detecting in vivo coating of red blood cells, which will aid in diagnosing conditions like hemolytic disease and transfusion reactions. We can also have antibody management, so for screening of specific antibodies to specific or identify potential incompatibilities before transfusions. And compatibility testing or cross matching, so confirms donor recipient blood compatibility, preventing adverse reactions. So that's it for this slide. And then well this slide covers four configurations of gel cards used in blood banking. So specific gel card configuration. So we have ABO blood grouping card for forward grouping with microtubes containing anti-A, anti-B, and anti-AB reagents for efficient blood type determination. You can also have ABO reverse grouping card, which uses buffer gel microtubes to interact with reagent cells and patient's serum to cross verify blood types. We have RH typing also, RH typing cards, which contains anti-D reagent microtubes to identify RH positive or negative status. We also have the RH phenotype card and the compatibility and antibody testing card. And the one that I haven't mentioned is our DG gel combs card for AHG testing. So these configurations ensure precision, reliability in blood testing for safer transfusions. And then for the principle, the structural design of the gel test. So the gel test in blood bank procedures features a microtube with two main components. We have the two main distinct components or parts that you need to really remember by heart. So we have the upper reaction chamber and the column. So for the upper reaction chamber, it's a wider area where red blood cells and serum or the plasma mix, allowing antigen antibody binding during incubation. We also have that column which is somehow long and narrow, which is long. It is a narrow portion filled with your dextran acrylamide gel particles suspended in a diluent. So that's the column. And then additionally, the gel card replaces traditional test tubes. So test tubes will no longer be used if you are using your gel card, of course. And then with a compact card containing 6 to 8 pre-dispensed microtubes with gel, diluents, and reagents. So these innovations enhance the efficiency of the testing process. So here we have the microtube. Again, what are the two distinct parts? We have the reaction chamber and we have the column. In the column, you can see the gel and the reagents. Okay? And the reaction chamber is where the reaction will take place, where your added reactants, your serum, your plasma, and or your red cells are being placed. So that's it. Then here, let's talk about the important role of the gel column during gel testing. So what's the role of the gel column? So first, consider the surface area of the column. So the column is specifically shaped and elongated to maximize surface area, which is crucial for the test's effectiveness. Next, think about the prolonged contact this design facilitates. So as RBCs travel to the column, they remain in contact with the gel particles for an extended period of time. This contact time is key to the test's accuracy. Finally, the separation mechanism comes into play. So the dextran acrylamide gel with the column functions as a filter. It traps agglutinated or clumped cells while allowing the free cells to pass through the bottom. So this filtering process is essential for distinguishing between different cell types during the test. Okay, guys? And then the focus of the next slide is on understanding the structural design of the gel test, no? Specifically of the gel card. So We are using a plastic card that measures approximately 5 by 7 centimeters. This is small, yes, it's small yet efficient design which is central to the test functionality. Within this card, there are 6 to 8 microtubes. These are the microtubes. These tubes are essential as they come pre-dispensed with the necessary gel, diluent, and reagents needed for the test. So this setup ensures consistency and accuracy in test results. So by having everything pre-dispensed inside here, we streamline the process, make it more efficient and less prone to human error. So this setup underscores the innovation in design, enhancing the reliability of the test. So this is an example, like and one configuration is for ABO typing. So it doesn't mean that if you're using the gel card, it can only be utilized for AHG testing. No, it can be used for RH type. That's what I have said earlier. So the very first moment that we will be using this gel card in blood banking in our laboratory exercises will be for AHG. And the next time that we will be using another gel card will be that for your cross matching and antibody screening and antibody identification. So another example, this is really the card that we will be using. So a visual cue for you is that inside the microtube, so the gel is somehow colored green. It's greenish. So if you can see something greenish like aqua or mint green, so it signals that it has AHG. It's for AHG testing. So next, principles. So for the testing process. So in this slide talks about the core steps of the testing process, starting with dispensing. Okay. So first, we measure precise volumes of the patient's serum or plasma or red cells, which are then added directly into the microtube's reaction chamber. And next, if the test requires it, such as with antibody screening, the card is incubated. This allows for antigen antibody interactions to occur, which is essential for the detection of specific antibodies. And finally, the card undergoes a controlled centrifugation process. This step forces the red cells down the gel column, allowing us to observe and analyze the reaction. So each of these steps, dispensing, incubation, and centrifugation, they really play a vital role to ensure the reliability of the test. So now let's move on to the materials that you'll need for the processes. So for the manual method, we will be using 10, 25, 50. No? So we use automatic or automated pipettes in our four different sizes. We have 10, 25, 50, and 1 ml. And these are crucial. Again, you should really follow the volumes. Okay, so next we have disposable pipette tips or pipette tips. So these keep our experiments clean and prevent cross contamination, which is important to achieve reliable results. And additionally, we utilize both glass and plastic test tubes depending on the specific requirements of the test. So now, moving on to the specialized equipment, so the Grifols diluent, incubator, and centrifuge each play a specific role in preparing and processing the DG gel card. So the Grifols reagent RBCs at 0.8% concentration are essential, as are the anti-sera reagents, which help identify specific antibodies. And finally, through optional means, the Grifols reader is a handy tool, but we don't have that. And these materials, guys, are for our manual method are still, they can, of course, they can give us efficient and effective results, setting the foundation for good testing outcomes. But it's really up to your skill also, because we need, especially for pipetting, so you should perform it well. And then here we have the Grifols diluent or the DG gel sol, which is essential for preparing the samples for testing. It's in ensuring accurate results also. And then of course, then we have the Grifols incubator known as Digitherm. So this incubator is designed to provide the precise temperature conditions necessary for optimal antigen antibody interactions during the incubation phase of testing. Finally, we use the Grifols centrifuge or Digispin. So this piece of equipment is vital for centrifugation processes to so that we can separate the red cells through the gel column. And then these materials are not just important tools, They are really the backbone of the DG gel card testing method. So this is actually the thing that you will be performing or following. This will be flashed by using a projector in your lab rooms. So this will serve as your guide, especially for your gel card method. So your anti-human globulin testing, AHG testing using the gel card method or technology. So you will be performing both direct AHG and indirect AHG. And then you will have a patient. You will be having actually three patients. So patient one for your direct AHG, patient two for indirect, and patient three to for the serum. So let's start with your direct AHG. So extract one EDTA tube from one patient, and that will be divided into two separate tubes containing 1 ml. So your 2 ml EDTA tube will be allocated into two new tubes and must contain, so you will allocate 1 ml to each new test tubes, clean test tubes, okay? So that you can make your red blood cell suspensions out from it. So you will be making a 1% dilution of the red cells of patient 1. So 10 UL red cells plus 1 ml DG sol. Again, only 10 microliter of your washed red cells. And then label the gel card with your group number, the date, and the name of the patient, and dispense 50 UL in the corresponding column. Centrifugation will be done by 9 minutes, and after, there's reading and grading of the reactions. And then you will be given an unknown sample under direct HG. So the same procedure, you'll prepare a 1% dilution of the red cells of unknown patient one sample. So that's your 10 UL red cells plus 1 ml DG salt. And then label gel cards and dispense 50 UL into the corresponding column and centrifuge for 9 minutes and read and grade the reactions. And aside from the two uh, separate direct AHG testing that you'll be doing as a group. So you will have the indirect AHG, extract one EDTA tube from patient 2. So from patient 2 this time for indirect. And then extract one red top tube from patient 3. And then make a 1% dilution of the red cells of patient 2, 10 UL red cells plus 1 ml Digisol. Label gel card and dispense 50 UL in the corresponding column. So get 25 UL of the serum from patient 3 and dispense it on the same column. Incubate the DG gel card for 15 minutes using the DG therm. And then place the DG gel card in the centrifuge, in the DG spin. That's our centrifuge, specially designed for this one, for 9 minutes using the DG spin. Yeah, that's it. And read and grade the reactions. So for the this time let's discuss about the stability and cost efficiency of the results obtained from using the DG gel card. So please do not leave process cards in a horizontal position. And if necessary, a delayed reading can be performed up to 24 hours after processing the cards. If they are kept in an upright position, refrigerated at 2 to 8 degrees Celsius, and sealed within laboratory film to prevent evaporation of the supernatant. And do not read the results of microtubes that has been centrifuged more than once. So there's no, you're not allowed to centrifuge it second time around. And in the 24-hour delayed reading of process cards with weak positive results, a loss in agglutination intensity may be observed. So for the QC, so the inclusion of a positive and negative control according to the laboratory's policies is highly recommended. We need to have a positive and a negative control if you are doing this, performing this testing. If an unexpected control result is obtained, a complete assessment of the instrument, reagents, and materials should be made or done. So this one, if you'll ask me where I got this, what's the source of this slide? The first one, the grading reaction was based on Harm Manning's Modern Blood Banking book. This one is from really the product insert of our DG Gelcom's gel card technology. So yeah, let's just go over with it one by one. So for a negative result, it's a well-defined pellet of unagglutinated red cells at the bottom of the gel column and no visible agglutinated cells or hemolysis in the rest of the gel column. How about positives? We have a something positive negative that's barely visible small sized clumps agglutinated cells in the lower part of the gel column and a pellet of unagglutinated cells at the bottom. 1 plus grading, so some small sized clumps of agglutinated cells, most frequently in the lower half of the gel column, and a small pellet may also be observed at the bottom of the gel. So, guys, I request you to use this grading because this is really the one coming from the product insert of DG gel combs from Grifols. And then for a 2 plus, we have small or a medium sized clump or medium-sized clumps of agglutinated cells throughout the gel column, and a few unagglutinated cells may be visible at the bottom of the gel column. Third, medium-sized clumps of agglutinated cells in the upper 3 plus, sorry, medium-sized clumps of agglutinated cells in the upper half of the gel medium. We have a 4 plus, which is a well-defined band of agglutinated red blood cells in the top part of the gel column, and a few agglutinated cells may be visible below the band. We also have DP, a band of red blood cells in the top part of the gel or dispersed throughout the gel column, and a pellet of unagglutinated cells at the bottom of the microtube. DP, or it's also known as mixed field, but as what I have read, it's really better to use the phrase mixed field rather than using the double population. So if you can see something like this, in which you can observe a band of red blood cells on the top part and a pellet of unagglutinated cells at the bottom, that's really a double population. But please do not give me an answer like something like DP or double population. Just use mixed field because it's recommended by the books, academic books. And then for H is hemolysis in the microtube with very few or no red blood cells in the gel column. So there's hemolysis, but the red cells are absent in the gel column. So annotate if hemolysis is present in the microtube but not in the sample. So this one is easier. See, this is hemolysis. And then this one is this is the blood, the black parts. See, if you can observe hemolysis happening here but not in the gel, that's hemolysis. And then this one, upper part, and then at the bottom, unagglutinated cells, there's a double population or a mixed field reaction. But I prefer you that you must answer me a mixed field reaction rather by using the phrase double population, okay? And then we have this one, 4 plus, down to 3 plus, 2 plus, 1 plus, then plus minus, and then you have your negative. So this one, the colored one, for you to easily see. And then for the interpretation of the results, so what does a negative reaction indicate? It indicates the absence of a detectable IgG antibody or IgG antibodies or C3d complement component on the red cells. How about a positive reaction? So it signifies that the patient's red cells are sensitized, RBCs coated with IgG antibodies and or C3d. How about your iAT? For your iAT, a negative screening indicates the absence of detectable unexpected antibodies in the patient's or donor's serum or plasma. How about a positive screening indicates the presence of unexpected antibodies in the patient's or donor's serum or plasma against one or more antigens present on the reagent red blood cells. So in case of positive screening, an identification panel should be done. So this is the next topic na, okay, for the screening and antibody identification. So next, guys, limitations of the procedure. So grossly hemolyzed, cloudy, or contaminated samples or samples containing a clot may give false positive or false negative results. So if you're using a hemolyzed sample, surely it will give you a false positive or negative results. How about aged or hemolyzed specimens? So yeah, false neg or weaker reactions compared to those obtained with a fresh sample, and samples with high potency antibodies may coat the red cells completely, so causing a spontaneous agglutination. How about your abnormal concentrations of serum proteins? Guys, the presence of macromolecular solutions in the serum or plasma, or the presence of Wharton's jelly in cord blood samples may cause non-specific agglutination of the red cells. So, also the presence of some drugs such as dextran solutions or the remains of silicone gel, sorry, from the reaction tube in sample may cause positive result in your DAT. Six, another limitation is the presence of high concentrations of IgGs or immunoglobulins and other serum proteins in the sample. It may lead to false positive result in antiglobulin tests. Seven, false positive results may occur if antibodies to components of the preservative solution are present in the sample tested. Eight, we have antibody activity may decrease in the elderly, of course, infants or persons with underlying disease conditions. We also have the use of papenized reagent red blood cells may lead to non-specific agglutinations in indirect antiglobulin tests, and if plasma is used, complement-dependent hemolytic reactions may not be detected. So centrifugation and repeating the test are highly recommended. We also have poorly anticoagulated plasma and completely clotted serum is used. So why? Fibrin residues may trap the unagglutinated red cells. So it will give a pinkish or reddish layer. So although the results may be correctly interpreted in a negative reaction, the false appearance of a double population may lead to misinterpretation. So in the case of incompletely clotted serum samples, reclotting the serum for 10 minutes at 37 degrees Celsius, centrifugation and repeating the test are recommended. We also have on occasion, unagglutinated red blood cells may be retained somewhere in the gel column, so appearing as a very minute red dot or fleck. So this non-specific retention, however, should not interfere with the interpretation of the result. And in your DIT, not all negative reactions indicate the absence of hemolytic disease of the newborn, especially in cases where ABO incompatibility is suspected. And then next, we also have lastly, remember that, yeah, yeah, so not all positive reactions indicate in data in the AT. Not all positive reactions indicate that clinically significant antibodies are present. So specific anti-IgG reagents and illusion techniques may be used for additional observation of positive results. So a false positive result in DAT, false positive result in DAT may be because of complement attached to RBCs in specimens collected from infusion lines used in to administer dextrose containing solutions in specimens collected in tubes containing silicone. We also have another one, non-specifically adsorbed proteins like high-dose IV immunoglobulins. We have a disease like multiple myeloma, autoimmune disorders, and other diseases associated with elevated serum globulin. And also the modification of red blood cell membrane by some drugs may cause a positive result in DAT. So if an unexpected result is obtained in DAT, washing the RBCs with physiological saline solution and preparing a new suspension of the washed RBCs and repeating the test are recommended. Okay, guys. So that's the end for AHG, and I hope you've learned something. And God bless and enjoy studying.